Okay, so any questions for pharm from any of the previous material? Nothing at all. All right, so we're going to continue talking about dose responses and kind of the variations in response that we can see when we're giving medications to people. So there's one thing we have called the rebound phenomenon. Has anyone heard of this rebound phenomenon before? Basically what's happening here is if you were to give a patient a drug for a given effect, so say for instance lower their blood pressure, and then you take that drug away, typically you would think that the blood pressure would just kind of come back to whatever their baseline would be. In some cases though, when you chronically give a medication over a period of time, you can actually end up seeing a more exaggerated overactive response. So their blood pressure may actually come up higher than what their baseline would have been previously. So a good example of this would be the beta blocker propranolol, which we said, beta blockers work to lower blood pressure. They lower heart rate by blocking those beta adrenergic receptors on those tissues. So normally when you give propranolol, you should see drops in blood pressure, heart rate. Okay, that makes sense. And so basically what you end up seeing is that the receptor regulation will change over time, where you're going to have some upregulation, and I'll show you a picture of that in just a second. But you're going to have some upregulation of those receptors. So the actual number of receptors that are present and can be affected by those endogenous ligands like epinephrine and things like that are going to be more numerous, right? So there's more of them to be affected. So when if you gave a beta blocker like propranolol to a patient, say over 6 months or so, if you were to abruptly cut them off cold turkey, they would end up having kind of a more exaggerated response because they have more of those receptors that can be hit by those endogenous ligands. So, imagine here if you had your normal receptors, receptors being those kind of squares. I guess I should use my laser pointer. So you have your receptors here, and you have your natural ligand. So this would be like epinephrine or norepinephrine affecting, say, the myocardial tissue or the vasculature or something like that. And so what would happen, say like their regular baseline heart rate and blood pressure. So say their heart rate is 75, blood pressure is 145 over 90, so a little hypertensive. And so let's say we gave some beta blockers. And so again, those are going to be competitive antagonists, so sitting right there on the receptor so they can't be activated by things like epinephrine. And you see their heart rate drops down to 60 and their blood pressure, say 120 over 80. Perfect. We want to keep them right there. Over time, you're going to find that the number of receptors are going to start to upregulate, right? Because the body wants to maintain homeostasis. For that person, this baseline, that's what their body is used to at this point. So it wants to try to get back to that by upregulating those receptors and expressing more of them. But if I were to take away the drug immediately, what you end up seeing is you have more of these receptors being activated by epinephrine or epi, and so you end up getting a heart rate that would go up, and blood pressure would also go up higher than what the actual baseline level was. And so you can see this, especially with things like, you guys ever heard of the drug Afrin? What do you use Afrin for? A nasal congestion, right? And that actually works as a vasoconstrictor in the nasal mucosa. And so what you end up finding with people who take that for too long, that's why they recommend never taking it for more than 5 days. When they stop taking the drug, all of a sudden their body's used to having that effect on them. They get this rebound nasal stuffing that's even worse than the whatever stuffiness and congestion they were dealing with in the first place. This can happen with a number of different drugs. You see it probably more frequently with antihypertensives and things like that, but we'll call it those specific examples when we get into pharmacology. Again, some genetic factors can play a role in receptor function and the number of receptors that are available and things like that. So, for instance, if you had this deletion in an alpha-2C receptor and this G protein beta-3 subunit variant, those patients end up having kind of an increased cardiovascular response to stressors. So they would have greater changes in blood pressure and heart rate in response to the sympathetic nervous system. And what you end up finding is this particular mutation tends to be 10 times more prevalent in African American patients than you would see in Caucasian patients. And in a lot of cases, this may or may not be clinically relevant, but just know that some patients are going to have inherently different responses to drugs based on some of their genetic makeup. Okay. So even though a drug is going to bind to a receptor, the intended receptor successfully, you can find that you can find other processes will reduce the effects of that drug over time. And again, going back to homeostasis, your body likes to maintain a normal, whatever its normal happens to be. So, and again, here we're going to be giving another beta blocker to lower blood pressure. And you're going to find that also going to be working in the heart to lower blood pressure. But over time, you may find that blood pressure is not really lowering as much as you would expect based on the dose of the beta blocker that you gave. And that could be due to compensatory responses elsewhere in the cardiovascular system. One of the big ones you'll see is this renin-angiotensin system within the kidneys. It's really important for regulating blood volume and also blood pressure. So you can have the kidneys actually try to hold on to more fluid and also cause more vasoconstriction of those vessels to combat the effects of that beta blocker, right? So this is sometimes why we use combinations of drugs with different mechanisms. That way you can target these kind of compensatory responses. Okay. So again, body generally tries to maintain homeostasis, so that way you can stay at its normal set point. All right, so looking at clinical selectivity and how a drug is going to be affecting possibly just one receptor, which would be very, very selective, or it could be non-selective, affecting lots of different receptors. It's going to be important when we're discussing the beneficial versus toxic effects of these medications. So again, drugs can be relatively specific for certain receptors. We mentioned beta blockers. They're affecting beta 1 and beta 2 receptors, right? You can have some that can be even more selective to that, some that are only going to be beta 1 selective. And we'll call those out as we come to them. But even though they can have their intended effect at certain receptors, you may find that there's other unintended effects that can occur at other types of receptors. In some cases, you're going to find that selectivity of drugs is very dependent on dose. So if I give you enough drug, if I keep driving that dose up higher and higher, you're going to start to lose that selectivity. And say, for instance, the beta blockers may not just, if I have a beta 1 selective drug that's only affecting beta 1 receptors, if I keep increasing that dose, eventually it's going to start to lose that selectivity and affect beta 2 receptors as well. Okay, so selectivity is always going to be a factor of dose. The higher up I drive that, the more likely we are to have other receptors being affected by that. And so we find it useful for things that have a higher selectivity because that generally is going to cut down on the number of side effects that we can see with medications. More selective, more likely to have less side effects, especially things that are kind of not really related to its mechanism. So for instance, when we're looking at pesticides, right? So typically we don't give people pesticides unless they have like lice or something like that. But you have kind of older pesticides, and actually sometimes I actually had a medic friend whose child ended up developing lice, and you'll find that lice is a resistance to a lot of the standard therapies is actually a big problem. You actually find that use standard therapies, try to get rid of the lice, and just come right back because they develop resistance to some of these drugs. And so normally we'd use things like pyrethrins that are really selective for just killing off the bug, the insect, and are not really nearly as toxic to humans because they're very selective and they're only really affecting physiology of the insects, not really affecting the people so much. Those are very safe drugs to give. May not be as absolutely effective as some of these other ones. So in this case, he was using a pyrethrin, realized it wasn't really working for his child's lice problem, so he ended up having to use an organophosphate, which is an older drug, much less selective. It doesn't really have as good a selectivity, meaning that it's going to be affecting the insect, but if you have too high of a dose, it could affect the person as well. So it's kind of one of the things you run into where you like to start with more selective drugs. Sometimes you can't necessarily get away with that due to other kind of competing issues. So just be aware that sometimes you have to utilize less safe drugs because of the fact that you've kind of run out of other options. His child did fine though, did not have any issues with the organophosphate. He was actually he was a very thrifty kind of person, so he realized, well, I can buy this bottle of malathion, which is an organophosphate, from the pharmacy for like $200 for the shampoo, or I could just go to the hardware store and just make my own. I said, that doesn't sound like a good idea, and he's like, it's fine, she did great. I was like, oh boy. Because I know I'm not a very good chemist when it came to lab. I had my teacher end up doing I had a sweet talker into doing most of my experiments, so I can't imagine a lot of other people doing it either, but his child did okay. So you can actually measure the selectivity by comparing binding affinities of a drug for different receptors by actually looking at the ED50s. So again, we talked about ED50 being that effective dose where you should be getting about 50% receptor occupancy for a given drug. And you can actually look at different receptors and see where those ED50s are, right? So we said that things that are going to be have a higher potency are going to be kind of farther to the left on those graphs, so you can end up seeing them having lower doses affecting getting to the ED50 quicker versus some things to be less selective, be farther on the right, right? Because you need larger doses in order to affect those receptors in the same way. And so generally when we're looking at kind of like drug development studies and looking at selectivity, you want to kind of separate these effects out into both the therapeutic effects that you're going to be seeing and then also the toxic / side effects that can develop as well. So looking at the beneficial and toxic effects of a drug that can come about from the actual same receptor mechanism. So sometimes you'll find that side effects of a drug come about from its actual mechanism. Sometimes you're going to find that the side effects are going to be unrelated. So the first ones we'll talk about are the ones that actually have its side effects through the same mechanism that the drug has. So again, this would be the case where a drug, a lot of times we're kind of looking at the dose that we're giving to make sure we're trying to target the beneficial effects without hitting the toxic effects. It's very easy for those to end up blending. And so a good example of this is warfarin, otherwise known as Coumadin. We mentioned in a previous lecture that's a blood thinner, helps to prevent clots from forming. So what you can end up seeing is that, yeah, we want the patient's blood to be in a certain level where it's not too thick, where it's going to clot, and not too thin, where it's going to end up bleeding out, right? And so it's really important to watch out for that, because you can end up seeing some pretty significant toxicity. Either GI bleeds that can develop from this if you don't have enough, if you have too much warfarin effect around. Stroke can actually happen. So I've seen a few hemorrhagic strokes that come about from that, from a patient who was on it, they fell, hit their head, and then all of a sudden they're bleeding out, right? But this is all through the same mechanism. So we want it to be a blood thinner, but you have to make sure you don't get too much of that blood thinning effect. Same thing for insulin. You have too much insulin, right? You want it to lower down the blood sugar, but if they get too much of it or they forget to eat or something like that, you can get hypoglycemia that can occur. It's all the same mechanism. It's just a further extension of its therapeutic effect into getting into more toxic effects. And here you got to really weigh the benefit versus the risk. So specifically, if you're looking at a patient like who's on warfarin, look at the benefit of, okay, well, we don't want you to have a stroke from your AFib, and that's why we want to prevent those clots from forming. We also don't want you to fall and have a head injury, right? And so that's why we're trying to balance out, like, okay, well, how, should you be on this drug? Should you be on a different drug instead? And so the risk factors kind of go into that, to deciding, is this a drug, a good option for that patient? So we'll talk much more in detail on those type of drugs and those different options you can have when we get into the next class. Okay, so again, you can have therapeutic effects that occur through one mechanism, and then you can have the toxic effects occur through different effector pathways. So a good example of this would be certain drugs. They can be used in one area of the body. So for instance, glucocorticoids, we talked a lot about those in physio already. So what did glucocorticoids do for us? Yeah, they suppress the immune system, good. Yeah, they suppress inflammation, absolutely. So those are really good effects we like for those, especially when you have when the respiratory tract is very inflamed, right? In the case of like COPD, or if you're having like an asthma exacerbation or something like that. So we like glucocorticoids because we can give them drugs like prednisone or methylprednisolone. I'm sure you guys have heard of some of those. That will be useful in helping to reduce the inflammation in the lungs, help to decrease some of that edema that's happening in the airway, and they can breathe much better, right? So that's a good thing. But what you're going to find is that you're going to have toxicities in other areas of the body because the drug is still having similar effects, which is being administered systemically. So you can see things like increased glucose, you can end up seeing diabetes and fluid retention, right? So again, we really, when we're giving prednisone to this patient with an asthma exacerbation or COPD exacerbation, we want to just target the lungs if we could, but in a lot of cases you have to use systemic drugs. So these toxic effects are in different tissues, right? Even though it's the same drug we're giving there. So again, you can have worsened diabetes, fluid retention, so like a patient with congestive heart failure, things like that can be affected by that. So ways we can get around that is to want to use the lowest effective dose that we can. So again, if you don't have to give them too much drug, you can try to get a little bit better selectivity via that mechanism. That's one way we can do it. You can use more direct routes. So for instance, if you have patients who are on like kind of long-term therapy for COPD or for asthma, we like to give inhaled corticosteroids, right? That way they can get it directly into the lungs. They don't get a lot of systemic effects, and they end up kind of being spared those toxicities, right? So that'd be one way we can try to target a little bit more effectively. Or we could use drugs with alternative mechanisms of actions, maybe using something that didn't exacerbate someone's diabetes but still dealt with some of the inflammation. Okay? So it's important to always know your different drugs in your armory that you can pull from in order to treat someone. So I actually had this come up yesterday where I was doing a site visit for a student who's out in rotation, and she was in a GI clinic, and it was like a 3-year-old. Her case was like a 3-year-old with constipation. And said, okay, well, we're going to give them Miralax, which is, you guys have heard of the drug Miralax. Common over-the-counter anti-constipation drug. It's pretty good. But I was like, well, what if that doesn't work? Well, I'm going to go to this. Okay, well, what if that causes toxicity? Okay, well, then I'll go to... So you have to be able to know several backups, so that way you know that, okay, well, if this doesn't work, or if this causes toxicity, I know I got these other drugs I can go to, either different mechanisms or different dosage forms, whatever happens to be. And you guys will learn that as you go into practice, and you'll usually have, kind of your go-to drug, and then a few backups that you can use whenever you need to. So you guys will learn that over time. Okay, so here we end up seeing toxic effects being mediated by different types of receptors as well. So you can end up finding that you have you'll have drugs like epinephrine, right? So that can bind to several different types of receptors. So you have like alpha, beta, and then also a few other receptors around the body as well. But by having drugs that are more selective, you can end up kind of trying to get just those therapeutic effects and avoid a lot of those toxic effects. So for instance, you can try to separate out, and so we'll talk about non-steroidal anti-inflammatory drugs and how they affect the enzyme cyclooxygenase, right? That's how they cause their anti-inflammatory effects. We can try to use drugs that are only going to affect one specific type of that enzyme. So you'll find there's going to be COX-1 and COX-2, and we like to find the COX-2 has a lot of effects on inflammation, but we like to have COX-1 around. We like to leave that one alone, and so we'll have some drugs that are trying to be selective for COX-2 to avoid those toxic effects. Again, these are just examples. Don't memorize this for the exam necessarily. Just know the concept and know that we'll get into more of this in detail much later. And then also looking at H1 versus H2 blockers. You guys know what the H means? Yeah, it's histamine blockers, right? So does anyone know any examples of an H1 blocker? Yeah, Benadryl is actually a good histamine receptor 1 blocker. So think about like your other kind of common cough and cold drugs. So think about chlorpheniramine or doxylamine or Benadryl, diphenhydramine. Those are all really good H1 blockers, but you'll see those have a specific set of side effects. Things like dealing with causing sedation and different things like that. Versus we can have things that are selective for the H2 receptors, which you find mainly in the GI tract, and that'll be where you have things like Zantac come in, right? So things that are going to be helpful for GERD symptoms. Again, we'll get into more details on that, but just know that selectivity is really generally a good thing, and we generally try to be as much selectivity as we can, because that helps to limit a lot of those side effects. Again, this gets really important. So like when we're looking at disease states like rheumatoid arthritis, or we're looking at things like certain cancers, you're going to find that we'll have some drugs that affect basically all cells within the body. They cause a lot of side effects. And then there's a lot of newer drugs that are coming out that are targeting very, very specific molecules. So in the case of like rheumatoid arthritis, we have steroids that we can use that affect the entire body, lots of side effects. Or we can have these proteins that affect just TNF-alpha, right, or interferon, or just little things like that, where it's much more selective. Get much less side effects out of that, but also you run into things like more expensive drugs and some other problems. But selectivity is a good thing generally. Okay. Sometimes you can actually have unintended side effects actually lead to a new use for a drug. So minoxidil or Rogaine is actually a really good example for this. Minoxidil is actually a vasodilator, and so they originally tried using it as a blood pressure lowering medication. Then they realized they had all this increased hair growth that's happening to these patients. They said, well, let's just try using it for that. Let's try using it topically, and all of a sudden now you have Rogaine, right? Actually, I had a patient, if you ever look at the ingredients on Rogaine, you'll find that it has a high content of alcohol in order to let the drug go into solution. And so we had one alcoholic patient who decided to drink a bunch of this in the Walgreens. And so, as you might imagine, he didn't really get a whole lot of hair growth effects immediately, but he did get profoundly hypotensive. And so, again, seeing how these drugs are working, you wouldn't, if you didn't know that original use for the drug, you may not realize that would be an unintended side effect. But yeah, this guy came in super hypotensive. We're having to give him tons of fluids, tons of vasopressors. Very, very, very sick patient. Fortunately, was able to make it through, probably to overdose on some other alcohol-containing substance later. But regardless, we were able to kind of figure out, like, okay, we know what this drug is doing. We can combat that by giving appropriate counter drugs. Okay. So again, when you're selecting an agent for a particular patient, for a particular disease state, you have to consider things like the side effects. You have to look at potential toxicities that patient can develop, and also the duration of effect, right? Sometimes you want things that have a very long duration of effect. Sometimes you want things that have a very short duration. And that is going to be factored into every single patient. Is going to be a little different than one another. Looking at the potency or looking at the efficacy does not always mean that one drug is going to be best for a particular patient, right? Potency is not really a big deal because we have our doses set to where we can take that into account already. So it doesn't really matter if something is dosed in grams or milligrams. That's already been taken into account for the efficacy that the drugs have. But again, I can have a drug that is super effective for treating this one particular disease state, but if it causes such bad toxicities that the patient can't bear it, their quality of life has even suffered further, then that's not a good drug for that patient. Right, so you always have to kind of look at both sides of the coin there to make sure you have the best drug for that patient for that condition. Okay, so any questions on the end of that section? Yes, ma'am.
So Rogaine, do they now make it where it does not lower your blood pressure since it's purely pretty much just used for hair growth?
I mean, that's what the drug does, So like.
Just warn people on the...
Well, I think it being Rogaine and they market it as being a topical product. The intention is that no one drinks it based on that. But again, people will do some odd things. Or bless you. Or if you had a child who was going around rummaging around the bathroom and found a bottle of Rogaine and drank that, that could be another case where you could see unintentional ingestion of some of those substances. Yep, so unfortunately we'll never be able to get away from the fact that Rogaine causes that profound hypotension, but just in the majority of patients it's not really a big deal, right? Because most people are going to use it appropriately, right? It's just like when you guys ever heard of like K2 or Spice, the synthetic cannabinoids that came about. Did anyone ever like look at some of the packaging on those when they were like available, so like in gas stations? see like what they said, like, about as far as use of the drug or use of this incense. It's not for human consumption, right? So by putting big letters "not for human consumption" on there, it's like, well, people aren't going to ingest this, and then sure enough, people are smoking it like crazy, and But that was one of the ways they try to get around the kind of legal ramifications of that, and obviously they realized that, hey, this stuff is bad news. So they put it under Schedule 1, and now it's, still get it on the internet, of course. But fortunately, I was able to buy one package of it for my little tox paraphernalia. Not trophy case, I guess, but for a little display before it became illegal. I guess it's a felony. I shouldn't have admitted to that, but especially on the recording. But for it's good illustrative purposes, like nice little bit of history there. So anyway, don't do drugs; they're bad. All right, moving on. Now we're going to get a little bit more into pharmacokinetics. So we're going to look at the absorption, distribution, metabolism, and elimination of drugs. All right. So again, we said pharmacokinetics is what the drug does to the patient, or the body does to the drug, right? So the body is going to allow for absorption of some drugs, going to prevent absorption of other things, distribution, how it metabolizes that drug, and how it eventually eliminates it from the body. We're also going to look at things like loading doses, we'll look at steady state, and then also how that relates back to toxicity. So again, drug distribution and metabolism, we're going to be looking at how we can interpret the volume of distribution of a drug relative to actually how that drug is going to distribute out to the tissues. Does the drug like to stay within the central circulation in the bloodstream? Does it like to partition out to the tissues? All that can have big effects for how the drug is going to be working. We'll talk about major pathways for metabolism. Most metabolism you'll see is going to happen in the liver, and you're going to find how other disease states and things like age can have an effect on how metabolism occurs. We'll look at, again, kinetics of the drug absorption, talk about ways how the drug actually gets absorbed into the body and ways we can alter that based on the drug. And we'll also look at elimination. You guys know where the biggest place that drugs get eliminated from in the body? The kidneys are the biggest place for excretion. Know any other places drugs would be? So the liver is where a lot of metabolism occurs, but the bile tract is where you can see some drugs being eliminated there as well, right? So think about the biliary tract as being a place where drugs can also be eliminated. Those are probably the main ways that occurs, but we'll talk about other ones as well. And we'll also look at things like half-life, look at clearance, and how we can kind of equate that back to how long a drug is actually going to stick around for and have its therapeutic effects. Okay, so essentially when we're looking at pharmacokinetics, this is basically you give a dose of a drug, right? Depending on the dosage form that it's in, you may need some drug liberation. What do you think drug liberation is? I don't say work, but if you think about like a tablet, when it gets into the GI tract, like it has to dissolve first, right? There's actually some really good, I saw some good GIFs on the internet maybe a few weeks ago. They're putting like Advil caplets and things like that into water, and you actually see them kind of disperse. It's interesting kind of seeing how that actually occurs. But that liberation is the drug becoming free, essentially. And so once you have that, then the absorption phase will occur, right? And so depending on how we administer the drug, you can have complete and total absorption. You may have very little absorption, especially through the GI tract is where you're going to have the most kind of variability there. What's one way we can have 100% absorption of a drug? Yep, IV is going to be one of the biggest ways we can do that, absolutely. So anyway, so then you're going to have free drug that is going to be, say, within the bloodstream at that point, right? So we're going to call this the central compartment. That'll be basically, if a drug is in the bloodstream, it's considered to be in that central compartment, essentially. So that free drug is really important because free drug is going to be physiologically active drug. If the drug is free, it's able to get to its receptor, wherever it happens to be, and is able to be active, okay? So what you're going to find is that some drug ends up getting bound by serum proteins. We'll find that albumin is going to be one of the biggest things that can bind up drugs and hold them in the central circulation for a period of time. You will find that also some drug is going to be partitioning out into the tissues. Now, some drugs only work when they get out into the tissue, so this may be also where they're going to be working. You can find drugs will have some degree of tissue binding, but again, free drug is what's going to be physiologically active. Okay. Again, this is going to be an equilibration. Things are going to be kind of going in and out of their site of action. Eventually, they're going to be getting to a point where they're undergoing biotransformation. This is that metabolism that we'll talk about. Most of it's going to happen within the liver, but you can see some of it in the bloodstream. Some of it occurs in the kidneys. Just, lots of different places this can occur. You get these metabolites. In general, our body, when we're trying to detoxify drugs, we're trying to get them in a more water-soluble state so they can be eliminated either through the biliary tract or the kidneys primarily. And so we have this excretion phase that occurs here, and this will be termed clearance. Okay, So it's basically the whole fate of a drug from absorption after it's given all the way to when it's being eliminated from the body. And notice these are all going to be kind of equilibriums. This is all affected by the dose of drug that we're giving, by how quickly it's being metabolized. All these things are being affected, are factors in how a drug's going to be working within the body. All right, so first thing we'll look at is going to be absorption. So we've covered this a little bit already in physiology, but again, permeation is going to be where we have moving a drug through some of these physiologic barriers. So things like the intestinal wall, capillary walls, blood-brain barrier can be a big one, especially when we're looking at things like meningitis. Like, what is meningitis? Yeah, inflammation of meninges, usually caused by bacterial infection, right? So when you're looking at, we need to treat the inflammation's happening there. We know we have these bugs that are in the central nervous system. We need to get drugs into there, and if the blood-brain barrier is not preventing those drugs from getting through, the drug's never going to be effective, right? So we're going to look at things like that and how a drug can be absorbed into different sites and how it can have its mechanism there. So again, aqueous diffusion is going to be a big way that a lot of these drugs get absorbed. So this can be through a passive process. Again, it's going to be just kind of passively going through the lipid bilayer there. Again, typically driven by the concentration gradient from high concentration to low concentration, just like we talked about previously. Again, this lipid diffusion is going to be important for things. There's a lot of lipid barriers, a lot of lipid bilayers that a drug has to pass through in order to actually get absorbed into that central circulation. What we're going to find is that most drugs are either going to be weak acids or weak bases. And so based on the pH of the substance that the drug is in, that will allow a drug to be more water soluble or more lipid soluble. Now obviously we said things are more lipid soluble are going to have an easier time going through those membranes, have an easier time being absorbed. And so affecting the pH of the drug, the solution that the drug is in, is going to affect its charge state, right? And we'll look at some examples of that a little bit later and showing how that has an effect on drugs being absorbed. We can also see carrier-mediated diffusion. Again, sometimes that'll be just a passive process where we're not actually expending any energy for that to occur. But again, when it's active, when it's actually utilizing ATP, things like that, that's going to be able to allow it to drive it from an area of low concentration to an area of high concentration, right? So we're pumping against the concentration gradients. That's also possible, but only through active transport there. We'll find that some drugs are very large and they have a hard time getting through a lot of lipid bilayers, and so those may require things like active maybe that facilitated diffusion where you have things like pores that form, or you have certain transporters that help get drugs through as well. Again, if it's not using any energy, that's going to still be a passive process and is going to go from high to low concentration. Again, we'll find this aqueous diffusion is occurring in kind of larger aqueous compartments of the body, and so think about things like passing through endothelial layers, passing through, getting to the blood vessels, going between the blood and the extravascular space. So again, still staying within the extracellular compartment, but being able to transition between those different aqueous phases, and that's going to be governed by Fick's law. Has anyone heard of this law before? Anyone ever met Dr. Fick? I didn't either, but his law is pretty good, and so we're going to be looking at this. Very important thing for allowing us to see how aqueous diffusion of a substance can occur. Again, this is going to specifically concern aqueous diffusion and passive diffusion of molecules going along their concentration gradient. So basically what we're looking at is that the amount of flux that we have, or the ability for that drug to partition through a membrane, is going to be determined by this concentration gradient. So we're looking at the concentration C1 versus C2. So this would be the concentration on the outside of the membrane versus the concentration on the inside of the membrane, right? Typically C2 should be lower, otherwise this diffusion is going to happen in the opposite direction. We're also going to look at the area, so the amount of surface area that we have for the drug to partition through. We'll look at this permeability coefficient. A lot of this has to do with how lipid soluble the drug is going to be. And then we'll also look at the thickness of the membrane. So notice how this is the denominator here. So that means that things that are more thick, what do you think that'll do to flux? Yeah, it's going to be harder to get through, right? So we like thin membranes. It's going to be easier for drugs to pass through. So again, so thickness is going to have a kind of inverse relationship to the amount of flux we have. So the bigger the concentration gradient, the more flux we have. The bigger the area that we're covering, the more flux you have. And then also the more permeable the drug is, you're going to have more flux. Okay, the only thing that is going to negatively affect this is going to be the thickness of that. Okay. So again, larger quantity, larger concentration gradients are going to have faster absorption, diffusion of this. We mentioned that drug absorption is going to happen a lot faster in organs with large surface areas. So you guys remember looking at the large intestine. having those villi that allow it to have increased surface area to allow for better absorption of drugs, versus the stomach really doesn't have that kind of surface area. So we have a lot better absorption in the small and large intestine than we do in the stomach. You find that drug absorption is going to be faster with thin membrane layers, so things like the lungs, very thin membrane, because remember, the lungs are where we're having diffusion of oxygen and carbon dioxide, so you want thin membranes there. So that's going to be faster distribution than we would see with things like thick membranes like the skin. Right? Integumentary system is meant to protect us from things getting in, but we can have certain drugs still partition through, but it happens more slowly. And then the body's way is basically, the body's way is trying to establish a steady state for the drug. We'll talk about that term a little bit later, but steady state is going to be a really important concept to understand for how and when you're assessing how drugs are working. So looking at this, you can see here how having a larger surface area allows for more drug to pass through. Having a larger concentration gradient from outside to inside is important, and also thickness is going to be affecting this. So a really good example of this is going to be with transdermal drug administration, right? So we said that usually the skin is meant to be protective and prevent things from passing through, correct? And so, but we still have some drugs that we give transdermally. Can you guys think of any drugs that we would do transdermally? Yeah, lidocaine's a good one. So we have lidocaine patches that can be useful. Yeah, nicotine patches are a really good example too. That would be intramuscular injection actually. Yeah, so if the needle's breaking the skin, then that would not be considered transdermal. We talked about like transderm scope, or the scopolamine patches you would use like before a cruise, right? And then also like fentanyl patches is another big one, right? In the middle of an opioid epidemic, fentanyl patches is a huge thing. So what you have to realize though is that drugs like fentanyl patches, they don't work immediately. I just can't slap it on the skin and all of a sudden the patient feels better, right? It takes time for that diffusion to actually occur, and so we run into this pretty frequently over, like, say, in the ICU. We have a patient who are treating for chronic pain issues or something like that within say like a fentanyl drip. We give them a drip, in order to control their pain, which means a continuous infusion of drug. And then what we'll do is we'll actually slap on a patch at the same time that they still have that infusion going, right? And so that way you still have drug going in, but it's taking time for that patch to actually start to partition through. So then as you go to the next day, say 24 hours later, you start to cut that drip, cut that infusion down, and then now because you're having some drug actually go into the skin. And at some point you're going to reach an equilibrium where you're actually having a good amount of drug coming through the skin, and at that point you can be changing out patches, so that way you keep that good concentration gradient. And so, again, patches rely on having a very large concentration gradient, so even though you're done with the patch, there's still a lot of drug left in there. That's where we run into problems with pediatric patients where they actually will pick up patches out of the trash can or something like that, eat it, and they still have a lot of drug in there, so that can be very problematic. So a really good example of how this can lead to toxicity, though, especially when you're comparing pediatric patients versus adult patients. How do you think the skin differs between, like, say, an infant versus an adult patient? Who has thicker skin? Probably the adult, right? Adult has more kind of developed an integumentary system. Probably the adult has a lot thicker skin. So we had one case where there was a dad who had chronic pain issues, and he had a specially compounded cream. It had things like ketamine in it, which I've kind of talked about ketamine before. It had things like amitriptyline, which is an old school antidepressant, but we'll still use it for neuropathic pain. Had all kinds of different stuff in here, right? And so he would put it on his back and hopefully help with his low back pain. So what ended up happening one night is they had a young infant who just had a bath, and the mom was going ahead and was getting ready to put the diaper on, and went ahead and put some diaper cream on, what she thought was diaper cream. Ended up being this dad's lower back pain cream, right? So she ended up slathering the backside of this kid's bottom up with this cream, put a diaper on. You'll also find that the more occlusive a dressing is, or when you cover something, that also increases absorption as well. And so basically cover this thing up. Kid had nice hot flush skin from having a warm bath, and put this occlusive dressing on, then said, okay, go to bed. Come in a couple hours later, kid's apneic, call 911, get the kid into the ICUs, intubated. Kid ended up doing fine, but they actually were able to measure levels of all of the drugs, right? So even though the dad probably didn't have a ton of absorption into the systemic circulation, this kid did, because his skin was so much less developed and was much more thin. Okay, so just keep in mind those kind of factors and how that can affect how patients can have different effects from even the same type of product. Okay. Does that make sense? Yeah. So again, looking at lipid diffusion, lipid barriers are going to be a pretty significant barrier to absorption. So if something is not very lipophilic, it's going to have a hard time getting through unless there's a specific transporter for it. There's some other thing that we can do to make it more lipophilic. And so the pH of the medium that the substance is in is going to dictate how well that drug crosses over. We'll look at why that is in a second. Does anyone remember the Henderson-Hasselbalch equation? Yeah, if I hear a few groans, that's going to come back in a big way. But basically, pH is going to dictate the ionization state of a drug. Okay, this means that when we have a drug that has a charge on it, that means it's going to be more polar, which means it's going to be more lipid insoluble, but more water soluble. This means it's going to have an easier time being dissolved in water, harder time crossing those lipid bilayers. On the other hand, if you have an uncharged drug, you're going to have it be more lipid soluble and more water insoluble. So that's going to have an easier time getting into crossing those lipid bilayers. So again, we like uncharged drugs for drug absorption. Charged things tend to stay on one side of the membrane or the other. And so knowing the pH of the solution that we're in, and also knowing the drug pKa, is going to be really important for determining how well that transport actually occurs. And I'll show you some clinical examples of why that is really important for us. But basically, weak acids and bases are described by this Henderson-Hasselbalch equation, and we can actually compare the pH of the substance we have versus the pKa of the drug, and can determine how charged or uncharged it's going to be. So again, pKa is going to be considered this acid dissociation constant. And so essentially one thing you can remember is that if you have a pH of a solution, if you put a weak acid or a weak base into that solution at the same pKa, you're going to find that the molecule will be 50% protonated, 50% unprotonated. Depending on whether it's a weak acid or weak base, that'll mean that 50% is charged, 50% is uncharged. Okay? So when the pH equals the pKa of that drug, 50-50. Now, the nomenclature that we're going to use for this is when you have HA, that's going to be a protonated acid, which means it's going to be in an uncharged state, right? Because normally acids, when they're non-protonated, they're going to have this negative charge on it. Again, this is going to be more water soluble. This is going to be more lipid soluble because it's uncharged. On the other hand, when we're looking at weak bases, you're going to find that when weak bases have an extra proton on it, they're going to be in a charged state. So it'll be a protonated base is going to be charged, have a harder time crossing lipid bilayers. On the other hand, when you have just the base by itself, unprotonated, that's when it's going to be in the uncharged state. So notice the flip side here. So if I were to have, say I put a weak acid into a more acidic medium. So again, acidic mediums have more or less protons floating around. They have more. You're going to find they're going to have a higher proportion of this of a protonated acid. It's going to have an easier time absorbing, right? So remember, I always say like dissolves like. So if you put a weak acid into an acidic solution, it's going to have an easy time being absorbed. Put a weak base into a basic solution, it's going to have easier time being absorbed. Okay, look at why that is when we get to the equation. Okay, so looking here, we have a lipid bilayer that we have both a weak acid and a weak base trying to cross. Notice here, when you have the HA, or the protonated acid, it's going to have an easy time crossing this membrane because it has no charge on it. It's going to be more lipid soluble. Notice there's going to be an equilibrium here because based on that Henderson-Hasselbalch equation, there's a proportion of drug that's going to be protonated and another proportion that's going to be unprotonated, depending on the solution that we're in, whether it be in the stomach where it's very acidic versus say the small intestine, which is be more basic. That's going to be affecting how well the drug gets absorbed. On the other hand here, when we're looking at the weak base, when the base is in the unprotonated state, that has an easier time being absorbed. It's very lipid soluble versus when it has and it's more protonated, it's going to be charged and it's just going to bounce off that membrane. Okay. It's important to keep this, keep that differentiation in mind between the weak acids and weak bases. So again, looking at the Henderson-Hasselbalch equation, what we can see is that pH will equal that acid dissociation constant here, so pKa, plus the log of the ratio between the unprotonated species to the protonated species. What that means is when you're looking at for weak acids, the pH is going to equal pKa plus the log of the unprotonated charged acid versus the protonated uncharged acid. And then for bases, it'd be the same thing, except we have the unprotonated uncharged base versus the protonated charged base. Okay, and so again, we'll talk about this in more detail, but questions may come up on a test where we say, hey, you have a drug that has a really, this pKa, and you're putting it in this solution, is it going to be more in the charged or uncharged state, and how well would that be able to be absorbed across the lipid bilayer? I'll show you some examples of that, but essentially those are kind of the things you should be able to figure out based on just looking at some of these factors here. So again, when the pH is equal to pKa, you should be having 50-50 split between having protonated versus unprotonated, right? And so by shifting this either way, so say for instance, if you shift the pH of the solution down to be more acidic, we have more protons here, you're going to find you have a higher proportion of the uncharged acid, HA, versus the charged base, BH+. Okay? On the other hand, if you were to make this more basic, decrease the number of protons that are floating around, you're going to have a higher proportion of the charged acid in the uncharged base, in the unprotonated state. Okay. So that means in an acidic solution, the weak acids are going to be more protonated, meaning they're uncharged and they're more lipid soluble. Meaning that if I say, for instance, I have the weak acid aspirin. If I put aspirin into a more acidic solution, it's going to have an easy time being absorbed through lipid bilayers. Okay. If you're looking at, say, like weak bases, on the other hand, it's in a more acidic medium, it's more protonated, it's going to be more charged, it's going to be more lipid insoluble. It's going to have a harder time being absorbed through those lipid bilayers. So morphine is an example of a weak base. Its protonated form is going to be less lipid soluble. So just to give you an example, some weak acids and weak bases, things like phenobarbital, things like pentobarb, even acetaminophen, aspirin. Notice all of them are going to have a different pKa, and it means they're all going to be in a more protonated or unprotonated state based on the solution that they're going to be in. Versus some weak bases like cocaine, ephedrine, we have chlordiazepoxide. This is actually a benzo. It's kind of like Valium or diazepam, and then morphine as well. So a really good example of how we use this clinically is that basically when you have drugs being eliminated in the kidneys, there's some amount of reabsorption that occurs based on the drug. So for instance, with aspirin, when it's, and if you typically think of like, what do we say is a normal pH for the blood? 7.35, 7.45 is the typical range. And how about for urine? Typically more acidic, yeah. So usually like in the 5 range, 5 to 7-ish, So what you find is that when you have a more acidic medium like the urine, aspirin is going to be in which state? It's going to be more charged or uncharged? Uncharged, right? Because it's going to be more protonated because it's in an acidic medium. That means it can be reabsorbed through the lipid bilayer in the renal tubules. It could be fine, but if you have the case where you have, like, say, a drug overdose of aspirin, that can be very dangerous. And so actually what we can do is we can give a drug called sodium bicarbonate, which, what does that do to the pH of a solution? It should make it more basic, right? So we can actually give sodium bicarbonate. It actually will alkalize the urine, increase the pH, and now what does that do to the aspirin? It makes it more in the charged state, right? Because we're getting rid of a lot of those extra protons because they're combining with the bicarbonate. And so basically you have more aspirin in a charged state, which means it's going to be less likely to be absorbed by those renal tubules, and you just pee it right out. So we can give sodium bicarbonate to patients who have an aspirin overdose to help them to clear it more quickly. Yes, sir?
If the pH of the urine is, you said, around 5,
Mm-hmm.
and aspirin's pKa is 3.5, then wouldn't that mean it would be more unprotonated?
Yeah, you're absolutely right. So so if we were to plug this in, right? So say we had the pH being 5, we could look at the pKa being 3.5, and you can see the ratio between unprotonated to protonated the species, right? So you can actually see what that ratio is. Yeah. Yep. Exactly. So you'd have more reabsorption. Some of it would still be eliminated. Some of it's still going to be in a charged state because it's an equilibrium, but you're not getting as much of it as you can. By increasing the pH of, say, the urine from 5 to, say, 8, you're changing that proportion pretty significantly. So now you have like 99.999% of the aspirin being in a charged state. It's going to be eliminated through the urine, right? So you're absolutely right. So some portion of it is going to be eliminated already, but not all of it. Yeah. Some patients will try to do this with weak bases. They'll actually, amphetamine, methamphetamine, things like that are weak bases as well. So some people actually try to alkalize the urine to try to help reabsorb that drug even better. So that actually can lead to longer duration of action. I can't say that I would ever advocate someone doing that, but people have tried it before. People do lots of dumb stuff with illegal drugs. Okay, so continuing on, looking at special carriers. So some things will have special carriers that allow it to either be reabsorbed or eliminated depending on what tissue you're dealing with and all of that. So for instance, you can have amino acid carriers that are specific in the blood-brain barrier that allow amino acids to get in. Sometimes you have weak acid carriers in the renal tubules that allow for reabsorption. Okay, so we'll find specific examples as we talk about the individual drugs, but just know there are special transporters out there to facilitate movement of these species. And sometimes drugs can be too large to actually diffuse passively through the membrane. When they're too large, they require those special carriers in order to get into where they need to go. But when you're dealing with things that are going through transporters, things going through these facilitated diffusion, note that Fick's law doesn't really work anymore. Because essentially with fixed law, if I keep increasing the concentration gradient, I'm always going to get more flux happening through that membrane, right? On the other hand here, this is going to be capacity limited, meaning there's only so many transporters to get that drug to move somewhere. So once I hit my capacity, eventually I can't go any faster, right? So that's kind of the big difference with these carrier-mediated transported drugs. Basically, transporters become saturated, may require energy, which may outstrip potentially. And again, if it's going against concentration gradient, once you kind of take up all those transporters, you can't really go any faster than that. So a good example of this would be the MultiDrug Resistance, or MDR1 transporter. Another name for this is going to be P-glycoprotein. Kind of alluded to this previously, but this is a really important transporter that will send drugs outside of a membrane. So if I want to get rid of a drug, this is a good protein for that. So for instance, the blood-brain barrier, do you want a whole lot of like chemicals getting up to the brain? Yeah, you want to protect it. So you have MDR1 proteins that can just spit it back out, right? If it gets into the CNS, it'll just efflux it. Same thing for the GI tract. You'll find these being used to efflux drugs back into the gastrointestinal tract. And so this is really important because you can have substances that can come along and inhibit these proteins, which can affect how much drug isn't going to be in the system. So for instance, with grapefruit juice and statins, statins are drugs that we use for cholesterol. So things about like simvastatin, things about Lipitor, Crestor, those kind of drugs. Essentially, if I were to give grapefruit juice and inhibit this enzyme, or this protein, you would find that you would actually have less efflux, meaning that my drug levels in the body would actually rise because I'm not spitting out as much of it to the GI tract, which can lead to things like liver damage, can lead to rhabdomyolysis or muscle breakdown, so all kinds of problems. So it's really important to look at these drug interactions and food-drug interactions to make sure they're not going to have any issues with this, right? Does that make sense? Actually, I had one patient who, so I mentioned these are in the brain as well. It's really important for making sure to prevent absorption of that, of different substances. And there is a drug that you use for diarrhea. It's called loperamide. And it has the same kind of chemical structure as an opioid, something like morphine or heroin. But because the brain is able to spit it back out so effectively, you don't really get any kind of the high from that. However, if I were to inhibit that protein, all of a sudden I can absorb more of it. And so I actually had a patient who, she read this online or was able to deduce it herself, but she decided to take a whole bunch of an acid reducer called cimetidine, kind of similar to Zantac, and it was able to inhibit this protein with that drug and then take a whole bunch of loperamide with it. So that way this drug would be inhibited, or this protein would be inhibited, she would absorb all that drug into the CNS and then not be able to spit it back out, right? Again, they go to extreme lengths in order to get their highs satiated. But she ended up going into all kinds of cardiac arrhythmias and all kinds of problems just because she had so much drug on board. But just know that people can try to abuse these sort of drug interactions for their benefit, or it could cause harm in a lot of cases. Just don't do drugs. They're not good. Okay. Some other examples, some other multi-drug resistant proteins. You can see here how these are really important in the here in the GI tract. So they say like have an enterocyte and there's these villi here, help to increase surface area. You find PGP, multi-drug resistant protein 2. These are important for spitting drugs back out into the GI tract, right? So you absorb some of it, but then get sent back out. Some of them are used for actual to help and aid absorption. So you can see some of these spitting drugs into the bloodstream. Okay. Also really important for sending substances out into the bile caniculus. And that way you can actually have things be excreted through the biliary tract, right? So a good example would be things like estrogen-based products. When you give oral contraceptives to patients, a lot of that ends up getting recycled because as they get it metabolized in the liver, it gets sent out into the bile duct. Then the patients can actually reabsorb that and actually extend the half-life of that drug because you have this recirculation that actually occurs there. Any questions from the first half? Any questions at all? Let's got this down. All right, great. So we talked about endocytosis and physio already, but essentially for substances that are too large, you can end up having, or if it's impermeable to the cell membrane, basically the cell can be engulfed, or the cell can engulf the substance that you are actually trying to absorb. This more often happens with certain things like cofactors for different reactions, like B12 with intrinsic factor can be absorbed through this pathway, and then also things like iron. Like we'll talk about B12 when we talk about hemoglobin formation, but iron being absorbed through transferrin, like that, it all comes through endocytosis, right? And so exocytosis would just be the opposite. We're going to be basically opening up a vesicle and excreting some sort of substance. Basically, you can find examples of this like calcium being released into the bloodstream, certain enzymes from pancreatic cells. I mentioned, especially in the exocrine function, things like protease and amylase and lipase. And then a lot of hormones from endocrine glands can come out through exocytosis. Just a good picture kind of showing you how the process is occurring there, but you guys already know all this. All right, so that's absorption. That's how drugs actually get into the body. And next we're going to talk about where they go after that, right? In the systemic circulation, where do they go from there? And so we're going to talk about this term called volume of distribution. So this is always kind of a tough concept to explain, and it makes more sense when we kind of look at some examples of this. But essentially, if you're looking at volume of distribution of a drug, it's the apparent volume a drug would have to occupy in order to get the same serum concentration measured in the body. It's not a very good definition, but that's the definition we have. It's a theoretical number, essentially, though. And what it's going to be describing, though, and this is an important concept to get down, is it describes to you how far distributed a drug gets into the tissues versus how much of it stays within the central circulation. Okay, so after I absorb a drug into the bloodstream, if all of it stays within the bloodstream, it's going to have a very low volume of distribution. It's not really distributing very far out from where it got absorbed to. On the other hand, you can have things with very large volumes of distribution, which means that all the drug that was in the bloodstream can be partitioning out into the tissues, and it's just going to stay there. Okay, and so we can kind of figure out what a volume of distribution is based on the blood levels that we can measure of that drug, and kind of comparing that between different things. We'll look at a couple of different examples in just a second. So how do we actually measure volume of distribution? Basically, what we can do is utilize this nice handy equation here. Say, for instance, we have the volume of distribution for a drug. This is usually measured in liters, right? Because, again, this is a theoretical number, but it's going to equal the amount of drug in the body. So say I gave you an IV dose of a drug straight into the, and if I give you an IV dose, that's how much absorption? 100%, absolutely. So I'm going to give you 100% of the drug into the system, and then you're going to be dividing that by the actual concentration that you would get in the plasma. Okay. So again, for some drugs, I may give you that drug IV, and all of it stays in the central circulation, and I measure all of that right there in that concentration. Right. Some drugs, as they partition out to the tissues, when I measure that blood again, you're going to find that it's not there to the concentration decreases because more drug is left the bloodstream. So again, basically you can also look at this as being the volume of distribution will equal the D, which is going to be the total drug in the body, divided by the C0. And so this is going to be an important concept we'll come back to. That's going to be the initial concentration that we'll measure in the plasma. So a good example of this would be, say imagine I gave you 25 milligrams of a drug, and I administered it, and I measured a plasma concentration afterwards of 5 milligrams per liter. Okay. That means if I were to go and calculate this, I know that I gave a dose of 25 milligrams. I know that the volume of distribution I got was 5 milligrams per liter. So if I were to divide that out, I get a volume of distribution of 5 liters. Okay, that number in and of itself doesn't really make a whole lot of doesn't really matter to you guys. But by comparing different drugs together, you can see how the volume of distribution can change. But basically, things that have a high volume of distribution indicates that a drug is lipophilic generally and will be distributed extensively throughout the body. So the higher volume of distribution is, the more likely it is to be sent out, and especially into things like adipose tissue. Typically are very lipophilic. They can cross membranes very easily. They're going to get partitioned far away from the central circulation. Again, so I can give a dose of a drug. If I measure that plasma concentration, not much of it's going to be there because most of it distributes out to the tissues. Okay. So if we were comparing two different drugs, let's say we have a drug, drug A, which we'd say is hydrophilic. And it likes to be in the central circulation, likes to be in the bloodstream. And I have a drug B, which is going to be lipophilic, which means it likes to be partitioning out into the tissue. If I were to give 50 milligrams of each drug to two different patients, they are identical twins, right? So they should be identical in all factors. I give 50 milligrams of drug A to one and 50 milligrams of drug B to the other. I can divide out the concentrations that I get and end up finding what the volume of distribution is. So 50 milligrams, and say for drug A, for the one twin, I got 10 milligrams per liter. I can divide that out and get a volume distribution of only 5 liters. So most of the drug was still there in the central circulation, didn't really partition out too far. On the other hand, if I had the drug which is lipophilic, drug B, and the concentration in it measuring was only 0.5 milligrams per liter, right? So I gave the same amount of drug, but the concentration was a whole lot less because most of that drug went out to the tissues. If I divide that out, you end up seeing the volume distribution was 100 liters. Right, so essentially, when you're thinking about it, I put it into a much larger bucket, essentially. So that concentration is going to be a lot less. That makes sense so far? Yes, ma'am.
Are there like numbers that indicate like general ranges that
Yep, I'm going to get to that just a moment. But thank you for giving them a brief teaser. So what we typically do is because, for instance, like, look at your neighbor. Do you have the same amount of blood volume as your neighbor? Maybe similar, but it's probably a little bit different, right? Your weights are probably going to be a little bit different. And so what you can see is that typically you'll find that volumes of distribution per drug are going to be listed as liters per kilogram. And so based on the patient and how much they weigh, I can figure out what their specific volume of distribution is, but it will differ based on the patient. So a 100 kilo patient is going to have a different volume of distribution for a drug than, say, a 50 kilo patient. So that'll differ, but basically you can kind of equilibrate it out to liters per kilogram basis. And so you can see things like heparin, which you guys know what we use heparin for? It's a blood thinner. That will have a very low volume of distribution, say only 0.05 to 0.1 liters per kilogram. That means that it likes to stay within the bloodstream, which is probably a good thing because heparin should work on the blood, right? So that's a good thing. So we like it to be there in central circulation. Versus something like, say, digoxin has a volume distribution of 2 to 5 liters per kilogram. That means it does not like to stay in the bloodstream. It likes to get into the tissue. And actually, digoxin is interesting because it likes specifically to bind to the heart, which is a good thing because it works on the heart. And so most of it's going to be sitting there just directly on the heart. And if I measure the bloodstream, a lot of digoxin is going to be there because it's all on that tissue. In general, it's a good number to know. If a drug has a volume distribution of greater than 1 liter per kilo, we consider that to be a large volume distribution drug. If it's less than 1 liter per kilogram, we consider it to be a low volume distribution drug. Okay. So if I told you, said it had drug Y and it had a volume distribution of, say, 5 liters per kilogram, you'd say, would you find more drug after a dose in the bloodstream or in the tissue? You'd say in the tissue, absolutely right. So if you were to do an actual blood level, or say a tissue level, I did a biopsy and I measured the concentration there, you'd see it's much higher than it would be in the bloodstream. But we don't like to do that to our patients because it's not very, very nice to them. Biopsies kind of hurt. But this has really important clinical ramifications when you consider things like dialysis. We mentioned dialysis before, but what is dialysis? Yeah, it's an artificial kidney essentially, right? So we're giving them basically taking the blood out of their system, running it through a man-made dialyzer or membrane. We can pull things off of that. So that has really big implications for certain drugs. Certain drugs that have a very low volume distribution, that's all in the blood, I can filter those out pretty easily in a dialyzer, which means, if I had a drug like lithium is a really good example, where if I had a patient overdosed on lithium, or say they had kidney failure and now their lithium levels are building up, I can pull that off the dialyzer pretty easily because most of it's in the blood. Versus if I have something that's a very high volume distribution, it's all in the tissues, I can pull that blood out and I can try to filter as much as I want, but because all that drug's out in the tissues, it doesn't really pull it off very easily. So this actually helps us out from a tox standpoint where I say, well, can I dialyze this drug off? Can I get it out of the patient's system more quickly? And a lot of that has to do with the volume of distribution. So things that have a high volume of distribution, you usually can't because they're all in the tissue, versus things that have a low volume of distribution. And again, that 1 liter per kilo is usually the cut point that we use there. Okay, so again, another example, so say we're estimating plasma concentration. So say, for instance, I have a 70 kilogram male patient. If I were to give him 100 milligrams of drug C, and I know that drug C has a volume distribution of 0.6 liters per kilo, I can actually estimate what his plasma concentration is going to be. That can be very useful if I need to achieve a certain concentration to make sure that I get a dose enough high enough to cause my therapeutic effect. I don't want to get too high because I can see toxicity. So for instance, if I were to do this, and I can just rearrange my equation, using that same volume distribution equals dose over C0. Basically what I can do is I see that the volume distribution for him would be 70 kilos times that 0.6, which means I'm going to end up getting, that will equal 100 milligrams divided by that C0, which is what I'm trying to estimate. By getting that 42 liters, which I know is his particular volume of distribution for that drug, equals 100 milligrams over C0, I can just rearrange that. So I can do 100 milligrams divided by 42, and I can estimate that he would have a blood concentration of 2.38 milligrams per liter. That may be too low for him, maybe I need to bump up the dose, and maybe too high for him, maybe I need to decrease it. But being able to estimate that is good because I can figure out if he's going to be toxic or therapeutic.
Question?
Where's the 42?
I'm sorry?
The 42,
that was at 70 times 0.6.
Oh.
Yep. Yes, sir.
Will we need a calculator for our exam?
I will make the math easy enough that you don't need it. You'll have scratch paper. So again, this is more complicated than what you'll see on the exam. But you will have to do some easy calculations for some of this stuff, right? So I were to say, like, if I were to give you, the volume distribution of a drug and the blood level, you could figure out how big of a dose that patient got potentially, right? And so we'll talk about some other factors that can go into that, but there will be a little bit of math on there, but not hard math. We know that. Okay, so that's how the drugs will distribute out into the tissues, or not, as the case may be. And next we're going to talk about metabolism. So basically this will be the mechanism by which we can terminate or alter the biologic activity of a substance. And the main function we're trying to do here is we want to get it ready for elimination, right? So metabolism and elimination are not the same thing. Some of them may happen pretty close together, but you have to keep the kind of two processes in mind as being separate. Basically, we're trying to make substances more polar or more water soluble, so that way they're going to be more likely to be filtered by the glomerulus in the kidney and be eliminated. Okay, so that's the main point of most metabolism, is to make it more water soluble, more able to be excreted by the kidney. And so, again, these reactions are normally to detoxify or deactivate the products to less pharmacologically active products. Right, so that's usually what happens. Usually things go from being active to inactive. You may find that's not always the case. Sometimes you'll have active metabolites. Sometimes drugs are inactive and we have to activate them. We'll talk about prodrugs in just a minute. So that prodrug would be an inactive substance that has to be converted through metabolism before it has any kind of biologic activity. So did I talk about Vyvanse, ADHD drug? Right, so in order to prevent people from snorting it to get a high off of that, they make it so that the drug is inactive and it has to be absorbed through the GI tract and go through the liver before it becomes active. There's other drugs that do that as well. I'm trying to think of any good examples of that. No, nothing's coming to mind. The drug clopidogrel is an antiplatelet drug that we use for patients after heart attacks, or if they've had stents placed, things like that. So we'll come across those drugs and kind of showing some examples of how they are inactive initially, have to be activated through the liver to be in the active form. Another actually good example of this, you guys are familiar with the drugs ACE inhibitors? Right, so those are typically used for blood pressure, sometimes used for patients with congestive heart failure. Most of those actually come out as prodrugs as well. So for instance, there's a drug called enalapril. Enalapril is the inactive form, and once it gets activated by the liver after going through the GI tract, it turns into enalaprilat. Okay, so you just kind of put an AT on the end of it. So that means if I were to give that drug IV, I don't want to give the prodrug because not all of it's going to go through the liver to get the active form. So we actually give the active form already IV. So if you ever see enalaprilat, that's the IV form that we're actually administering. It's already in the active state. Okay. Sometimes we have to give prodrugs because that's the only way they're going to get through the GI tract intact. Sometimes we do it for other purposes, like I mentioned that Vyvanse. So it can all depend. Oh, look, I already had the example right there on the slide. There you go. So I'm not just reading off. But like codeine is another really good example here as well, where codeine itself has a very poor analgesic activity, but it gets converted over to morphine. We talked about patients having polymorphisms, or some of them can metabolize that too quickly, some not quickly enough, in order to get varying amounts of morphine out of that. Okay. All right, metabolism primarily occurs within the liver. It's the most important place, but we can see other metabolism occurring sometimes in the lungs to a small extent, GI tract, skin, kidney, other places as well, but primarily the liver is the most important one for us. Most of the enzymes that we use to metabolize drugs reside within the liver, and really, again, the goal here is to make things more water soluble so that we can eliminate them through the kidneys. We said that's not the only place excretion occurs, but that's one of the primary ones we're concerned with. So there are two main phases to these metabolic reactions. You're going to have phase 1 reactions, which is going to usually introduce or uncover some sort of polar functional group that provides sites and gets it ready for a phase 2 reaction to occur. Okay. Now, one thing students sometimes get tripped up on is not every drug has to go through phase 1 and then phase 2. Some drugs will only go through phase 1, some will only go through phase 2, some will go through both. Okay, they're not mutually exclusive. One does not beget the other necessarily. It just depends on the drug we're dealing with. But the reactions that are happening within each of those are different. Okay, so it's important to realize what the difference is there. But basically, major reactions we see here are things like oxidation, if we're reducing something. Hydrolysis is another really important one as well. Okay. Lots of different enzymes that can do this. We have things like plasma esterases, which can catalyze esters and break those apart. Amidases, hydrolases, lots of different ones. The most important one, the reason why I bolded it and underlined it because it is so important, is cytochrome P450. Has anyone ever heard of CYP P450 before? maybe here or there. This is super important for drug metabolism. If you don't get anything out of this talk, realize that this is super important. It will come up on the exam, I guarantee you. Okay, moving on, we'll talk about those more in detail, but phase 2 reactions are typically adding on some sort of functional group to increase that water solubility, right? So phase 1 reactions are really just trying to uncover something, usually trying to make something more polar directly. This, with phase 2 reactions, we're adding something onto the molecule. So this can conjugate certain functional groups. Glucuronidation is a good one. Sulfation, we're actually adding a sulfur group onto there. Again, remember, not everything has to go through phase 1 to get to phase 2. Some things just can go through phase 2 by itself. So looking at the metabolism, how this can occur. So for instance, this would be an example of a drug that would end up going through both pathways in some cases. So say for instance you have a drug coming through and going through the CYP P450 system. You can end up getting some phase 1 metabolites. Some of these may be excreted directly. Some of them may go through this glucuronide transferase, where basically glutathione gets conjugated on, and then now you have phase 2 metabolites. They can be excreted there. So you see there's multiple places where drugs can be excreted from. So phase 1 metabolites may be good for excretion. Maybe 30% goes through this, 70% goes through phase 2. It can vary based on the type of drug, and I'll show you an example of one that goes through multiple phases in just a second. So acetaminophen, a really good example of this. We mentioned acetaminophen, brand name is... All right, we use it for pain, fever, headache, yeah, all that good stuff. So acetaminophen, the metabolism is really, really important because we mentioned when you get too much acetaminophen, you get what kind of damage? Liver damage, right? So we want to avoid that. So for instance, if you're looking at the metabolism of acetaminophen, you can see that about 25, say 35% of it goes to the sulfation, right? So we add a sulfate group onto it. Sulfates are usually going to be pretty water soluble, and that can be eliminated directly through the kidneys. Okay, about 47 to 62% of it can go through this glucuronide conjugation, right? So these would both be phase 2 reactions, right? So it directly went into a phase 2 reaction where you're adding on some sort of more water soluble functional group. Okay, so big portion goes through glucuronide conjugation, part of it goes through sulfation. You don't have to memorize the specific example or the percentages here. Just realize the concepts that we're kind of talking about. Now, a small portion is going to go through this cytochrome P450 2E1 enzyme, okay, and you end up getting this this toxic metabolite called NAPQI or NAPQI, and basically this is what causes all the liver damage. Okay, a small portion is always going to go through this pathway, but we have detoxifying mechanisms to get rid of that, though. So, for instance, here, once you get the NAPQI formed, basically glutathione can come in, you glutathione conjugate it, and then it can get some other metabolites being made and be excreted. So a small percentage goes through this. The problem we run into when you have too much acetaminophen on board, either chronically or with an acute overdose, is that you run out of sulfate to add on to these molecules. You run out of glucuronide to add on, and so now you have such a large percentage of it going through forming NAPQI. A lot of it goes to that CYP2E1, forms NAPQI, and then you actually end up depleting this glutathione conjugate as well. So now you've exhausted all these other pathways. 100% of it's going through NAPQI, and that's where you see liver damage happen. Okay, so realize that these can be exhaustible. You can overwhelm these pathways potentially. You have to have the cofactors needed to actually have these reactions occur. And note, so these are phase 2 reactions. We said, what about the cytochrome P450? That's what type of reaction? It's a phase 1, right? So it's getting it more water soluble, getting it ready for a phase 2 reaction. Okay. But again, sometimes if you run out of that cofactor, that glutathione, you can't conjugate it, and then you get problems there. Okay. So again, this is just an example of multiple pathways, some of which are going to be more or less expressed depending on other factors that are going on there. Okay, so some other examples of enzymes we can see here. So we mentioned cytochrome P450. This one being a cytochrome oxidase, right? So these are going to be oxidizing things. You can see some dealkylation that can occur, different reactions that happen here. Again, phase 2 reactions are going to be adding on things, sulfate groups, glucuronic acid, glutathione, all of that. And sometimes you have some other enzymes that are important as well. So things like alcohol or aldehyde dehydrogenase, really important for metabolizing alcohol. Again, you can have pharmacogenetic differences in all these enzymes. Some patients may be depleted of one because they don't have the genes to produce that protein. Some may have overactive enzymes. It's all depending. And you guys remember the term we used to talk about these different genetic factors that affect drug action? pharmacogenomics, right? So this is where pharmacogenomics comes into play, saying like, okay, well this person produces way too much 2D6, and they're going to make a lot of morphine out of codeine, and they die from respiratory depression. That's pharmacogenomics, right? That would be, okay, we know patients from Mediterranean descent, we don't want them to be on that drug because they're more likely to express that, whatever happens to be. So that's going to be more and more important as time goes on, especially when you guys have been practicing for a while, especially for common drugs that we're administering, so things like warfarin and things like that. A lot of pharmacogenomics you'll run into. Okay, so the first pass effect, this is another important concept, and so basically this is the amount of drug that gets absorbed through the intestine, gets delivered to the liver, and is partially metabolized. I call this the liver tax when we give things through the oral route. Essentially, liver enzymes are going to metabolize it just like it would if it was coming through the bloodstream. And you're going to find that there's a reduction in the amount of drug that makes it to the central circulation to have therapeutic effect. This varies based on medication. Some drugs will have almost no first pass. Some drugs will have a lot of first pass to where you can't even give them orally, even though they get absorbed okay from the GI tract, but all of it gets metabolized in the liver. It's no good, right? So a good example of this would be ethanol. You can actually overcome the first pass effect of ethanol by giving it via different routes. So for instance, if I give it orally, as most of you guys probably have consumed it, at least at some point in your lives, it gets absorbed through the GI tract fairly readily, and then some small amount of it is going to be metabolized by the liver. So whatever gets to your bloodstream isn't the full amount of what you actually absorbed from the GI tract, right? Don't know the percentage off the top of my head, maybe 70%, maybe 80%, depends on the person. Now, on the other hand, if I were to administer this via a different route, say one that does not go to the liver immediately, you can end up getting a whole lot more alcohol than what you had bargained for, right? So there's been cases of rectal administration of alcohol, right? So we said that the rectum is highly vascular, has very easy to absorb medications from there. Just give suppositories and things like that. So there's been patients where people do like beer enemas and things like that and actually absorb a ton of alcohol, and not a lot of it hits the liver initially, and so they get a higher blood level than you would expect if it was via the oral route. Have you guys ever seen like inhalational alcohol? Like, there's a product called a Vaportini where basically you can use use liquor in this tiny glass globe, and you basically use a tea candle to vaporize, and you can inhale that. And again, goes through the lungs, highly vascular, get good absorption, and you bypass a lot of that liver effect. Okay, so there's ways to get around first pass effect. I'm not advocating for you guys doing any of these. Point was to shock and horrify you. Go ahead.
If you inject it in the veins, doesn't it have to go through the liver still as it circulates?
Yeah, so as it circulates, that'll undergo normal metabolism, but it's just that initial kind of, with all the drug coming through the liver before it gets to the central circulation via the oral route, like that's where you see the biggest first pass effect. Yeah, so some of it will still be metabolized, but it's not nearly the same percentage as you would see via the oral route. Right, and we've given IV alcohol before, right? So we used to use that when we had patients who drank radiator fluid or like windshield washer fluid. We'd have to give them IV alcohol, which had 100% bioavailability and didn't have any of that liver problem, right? Some of it would still be metabolized to the liver eventually, but it took more time. Again, don't do that, but people have died because of that. Because again, especially like rectal administration, or some patients would take tampons, soak them in vodka or something like that, and then either administer it rectally or intravaginally. They absorb so much of it they find them passed out and they stop breathing. Right. So lots of issues can come about for that. Especially kids don't know. I don't know if you've met any teenagers, but their knowledge of pharmacokinetics is fairly poor. So they don't realize the problem with stuff like that, and so that's where they can run into some issues. My daughter will be like the one example that actually knows all of them. I'm just kidding. Go ahead. You mean like intravascular ablation? Yeah, so we actually have an interventional radiologist that does that for some of our kids who have like vascular malformations. High concentrations of alcohol, think like 70%. If you think about like normal like liquor is usually like 40% or something. So we're using very concentrated alcohol that can actually be used to sclerose the veins, or basically kind of scar, have them scar over and prevent the blood flow that direction. Not really the same thing, but usually what they're using is they've used an IR guided catheter to the exact site where they need it, and they inject very small amounts, because otherwise if you send that systemically, that would cause more problems. But yeah, not really the same concept. Okay, good question though. Okay, so the cytochrome P450 system is the most important liver metabolizing enzyme system that we have. It's a phase 1 reaction. It's involved in biosynthesis and catabolism, and we're going to find that almost all drugs, Certainly there are some exceptions, but the grand majority of drugs end up getting metabolized to some degree by CYP450. Lots of drugs and chemicals involved here. Also, this is susceptible to many types of drug interactions. We'll talk about cases where you can inhibit the CYP450 system. Sometimes you can induce the CYP450 system. It's important to understand that interaction and what that will cause, what effects that will have on the drugs in the body. There's over 1,000 different individual enzymes that are identified, and you guys should be able to identify all of them. Just kidding. It's pretty easy though. But more than 50 of them are actually functional in humans, right? So they're at least of clinical importance to us. Essentially, the name where it comes from is you'll have, for all human cytochrome P450 enzymes, we talk about multiple forms. Those are called isoenzymes. So, 3A4, 2B6, 2E1, those are different isoenzymes of CYP450. And they're all encoded for by different genes. And so you can classify them into families, subfamilies, based on the amino acid sequence. And based on that, based on the naming convention, you can figure out what type of drugs it'll be metabolizing. So for instance, we're looking at CYP2D6. Right, so I'm talking about if you see something start with CYP, you know I'm talking about a cytochrome P450 enzyme. So I'm not always going to write out cytochrome P450, I'll just write CYP and then whatever the actual enzyme is. So the name for this one would be CYP2D6. I know that, hey, it has CYP, so I know it's cytochrome P450. 2 would be the family that falls into, which means that with other 2 enzymes, it'd have about 40% homology in their amino acid sequence. The subfamily is that going to be that D there. So about greater than 55% homology with other enzymes that have 2D. And then 6, bless you, will be the individual enzymes, the actual unique sequence associated with that. So I'm not going to make you memorize the actual reaction that's happening here, but just notice that this is going to be an oxidative reaction. Basically, you put in a drug here at step 1. It's going to go through this P450 reductase enzyme process, and eventually the drug that you're going to get out of it is going to be this ROH product. And again, anytime you put a hydroxyl group, does that make it more or less water soluble? It's more water soluble, right? Because that OH can dissociate and makes it more water soluble. So again, the end product here is something that's more water soluble, typically, usually getting it ready for elimination, or that can be a reactive site for a phase 2 reaction to occur. Okay. So lots of different drugs that are metabolized to these different CYP enzymes. I'll just make a note of a few here. Some of the more kind of interesting ones are ones of clinical note, but certainly you can have things like CYP3A4. This one here is probably going to be the most important one that you will encounter. Okay, this one is most important for metabolizing the biggest majority of drugs. And also can be affected by both inhibitors and inducers. We'll talk about those reactions, those interactions in just a few minutes. But 2D6 is another big one. I always think about 2D6 as affecting drugs that affect the heart and the head, or head and heart. And so basically a lot of psych meds, a lot of cardiovascular meds get affected by 2D6. Again, don't memorize these lists here specifically, but we'll talk about individual ones on how they can have these interactions that can occur here. But again, when I say induce this enzyme, what do you think that means? Yeah, encourage it. It actually makes it so that you have more of the enzyme. So you're actually going to start to transcribe more of the CYP450 enzyme and actually increase the levels of it. Okay. So what do you think that does to a drug metabolism? Should speed it up, right? So you have more enzyme available to metabolize that drug, which means you're going to be metabolizing it more quickly. So you can see drug levels of that particular drug that gets affected go down. On the other hand, we can have inhibitors that will actually go in and cause the enzyme to work less effectively. And so what do we think that does to drug levels? So if you have an inhibitor inhibiting, say, CYP3A4, what do you think that does to drug levels for things that get metabolized by it? Decreases? Should increase it, right? Because we inhibited the metabolizing enzyme. Okay, so this is an important concept to get now. It's how these interactions work, because this will come up time and time again, especially with like seizure meds, looking at cardiovascular meds. This is an important thing to get. So if I inhibit a CYP enzyme, that means that whatever drugs get metabolized by it are going to have higher levels because it's not being broken down as quickly. If I have an inducer, that's going to drive levels of the affected drugs down because the metabolizing enzyme is going to be more prevalent. It's going to be metabolizing more quickly. Okay. So, for instance, if you notice, there is a drug here called ritonavir. You guys ever heard of the drug ritonavir? Anytime you see a VIR on the end of a drug, typically it's an antiviral drug. But ritonavir is a really, really important drug for treating HIV. And so this is actually really important because we will give this drug as an inhibitor of CYP3A4 along with other drugs that can treat HIV. And so the drug itself has okay activity against HIV, but we give it with other drugs to increase their levels. So that way, instead of having to give HIV patients pills 6 times a day, maybe we only have it 1 time a day or twice a day. They have to take it, right? Because we can inhibit that enzyme and drive levels up of the other drugs. Okay, so sometimes we'll use this therapeutically. In a lot of cases, these are going to be drug interactions that we should either avoid or we have to adjust doses to overcome. And we'll talk about the specific examples when we get to pharmacology. So we're going to look at the different drug metabolizing systems. You can notice here we're looking just at the CYP P450 primarily, or phase 1 reactions here. Notice here that the lion's share of it's going to be through CYP3A4. Okay, that's going to be the most important drug metabolizing enzyme you'll encounter, and again also has probably the biggest number of interactions that occur, either both inhibiting and inducing it. Things like 2D6 are also really important, but just be aware that they're going to have varying degrees of the number of drugs that are going to be affecting there. And looking at your phase 2 reactions, things like glucuronol transferases, glutathione conjugation, all are going to be a little bit more evenly spread throughout there. But really the big thing to illustrate here is just how predominant CYP3A4 is in metabolizing drugs. Okay, so some drugs get metabolized in other areas, so you have non-liver areas like the gastric acids. Some things are acid labile, which means they get broken down by the acid so that they sometimes have to be protected before they can be absorbed. So a good example of this, you guys ever heard of proton pump inhibitors? Yeah, I think I mentioned the example previously, but basically what we can do is actually wrap those drugs, which are acid labile, they'd be broken down in stomach acid, wrap them up in a coating essentially that doesn't get dissolved until it reaches that basic medium. So you go through the gastric acid where it's very acidic, that basic coating still stays there. And once it gets down into the small intestine, then the more basic solution there will dissolve that. The drug can now be absorbed. So that's one way you can try to protect metabolism of drugs from actually allow it to get into the GI tract. Digestive enzymes can be important here as well. That's why why we can't give insulin via the oral route, right? Because insulin, we said, is a protein, just gets broken down by proteases. So that's why we can't give proteins orally. We always have to give them via injectable for the most part. There's some inhaled insulins, but we don't really like those that much. Sometimes enzymes in the intestinal wall. Gut flora is also really important as well. So this is where you can see interactions with antibiotics affecting gut flora. Vitamin K is getting kind of gets into a ready state for absorption via gut bacteria breaking, causing some reactions there. And so if you get rid of that gut flora, you may not absorb vitamin K as much, and that can cause problems with drugs like Coumadin. So just be aware the gut flora can be really useful here. Have you guys ever heard of the reaction between oral contraceptives and using a backup method of protection when you're on antibiotics? The worry is that you get rid of that gut flora, which is responsible for causing some of that recirculation of the oral contraceptives. So you think that your levels would actually go down and increase your risk for things like pregnancy. Okay, so that's where you hear that interaction. We'll talk more about that when we get to the women's health stuff. But just be aware that usually if you hear these kind of interactions, like there's a method behind the madness, and we'll uncover those as we get through the pharmacology course. Sometimes we don't know why we do the stuff we do, but we do it anyway. But some of them I'll give you explanations where I can. So there are problems that can come about with liver metabolism. So especially if you have liver disease, this can impair the ability to metabolize a lot of these substances. So things like alcoholic hepatitis. So usually chronic alcoholics have issues where they are not metabolizing drugs quite as quickly. They have cirrhosis, which you guys know what cirrhosis is. What is that? What is it? Yeah, basically like scar tissue, just this really fibrous kind of tissue in the liver. It's not really that functional, so that can lead to less enzymes available. Cirrhosis, so if you were to have a backup through the biliary tract and may not be able to excrete things appropriately, that could be one problem. Drug-induced hepatitis is a big problem we'll see with certain drugs, so we can actually cause liver damage for those patients and lead to some issues there. So lots of things that can affect liver metabolism of these substances. Renal disease we can see being an issue, especially if patients are not able to, the small number of drugs that get metabolized in the kidneys. If you have issues with like acute renal failure, so you have no blood flow going to the kidneys, that can be a problem. If you have things like renal artery stenosis, so blood flow is impeded. Diabetic nephropathy we'll see is a big problem, so that can affect metabolism as well. And then just cardiac disease. Anytime you have issues with blood flow, so things like congestive heart failure, we have a lot of backup of fluid into like the venous system. That impairs the amount of blood flowing through the liver. And anytime you slow blood flow through the liver, that also slows metabolism, right? Because if the drug's not making it to the liver, it's not going to get metabolized in a lot of cases. That can be one problem you run into. So a good example of this is lidocaine. I mentioned lidocaine being used as, what does lidocaine normally do? Yeah, it's a numbing drug. It's an anesthetic, but you can also use the anesthetic properties on the heart as an antiarrhythmic. And so if you had a patient, we can give it IV in that case. Basically, if a patient has congestive heart failure, they're having poor blood circulation to the liver, and so lidocaine gets metabolized much more slowly. So you actually have to cut your dose in half. Otherwise, a patient will have too much lidocaine, they can have CNS problems, and then other issues pop up. So just be aware, and that's why you see, when you're looking at drug dosing information for things, you'll see usually patients in renal failure, how you adjust the dose for that. That's usually based on elimination, but usually you'll find dosing adjustments for patients with liver impairment as well. And so that's where a lot of this comes from, is the ability to metabolize those drugs. The endocrine system can affect drug metabolism. We mentioned that hypothyroidism is going to slow the metabolism down, the body in general. That can affect drugs as well. Hyperthyroidism can speed that up, so some drugs may be broken down too quickly in some cases. Mentioned genetic factors, and then things like diet and environmental factors are really important here as well. Certain things can induce CYP enzymes, so think about like charcoal broiled foods. You can actually have some of those substances coming off the charcoal that you ingest through the food that can actually alter enzyme expression, can actually induce that. So which is important because it's summertime, people are probably going to eat a lot of barbecue, right? Grapefruit juice, really important for older patients because they end up drinking a lot of this. It's probably one of the few things that can actually stimulate their taste buds anymore, and so that's why they end up causing a lot of drug interactions there as well, right? Age and gender can affect this, especially in young children. They may not have expressed all these enzymes yet. We'll talk about that when we get to special populations later on in this class. And then any disease that inhibits hepatic blood flow can affect metabolism as well. Lots of things that can be affecting this. Okay, any questions on the metabolism? Again, remember, CYP enzymes are going to be the most important drug metabolizing system we have. It's not the only one, but it's the most important. And CYP3A4 is going to be one of the most important ones you'll deal with out of that system. Okay, so drug elimination, again, usually once a drug is being given, it can go through the cytochrome P450 system, generate some metabolites. This is the phase 2 reactions here. We have that conjugation potentially. At this point, once it's been metabolized, you can see some things either going through hepatic elimination, getting eliminated through the biliary tract, and then going through the stool. So some drugs can still be, you have measured levels of metabolites within the stool. Otherwise, it's going to usually end up going through the kidneys. And so a lot of drugs, especially those that are lipid soluble, can be freely filtered through the glomerulus. You guys probably haven't covered a lot of kidney stuff yet, but just know the glomerulus is where we see a lot of filtration occur, and a lot of drugs can pass through there pretty easily. There's a lot of large gaps for things, substances to get through. But we'll see that lipid soluble drugs tend to be reabsorbed very easily. Alluded to this previously when we were talking about pH and absorption. But basically, charged molecules do not readily get reabsorbed, so they get passed through the kidneys, get into the urine, and can be eliminated. And so we mentioned the urine pH typically is going to be a little bit more on the acidic side, but can range anywhere between 4.5 to 8, depending on what's going on with the body. Because again, the kidneys are really important for regulating pH within the body as well. So things like excreting bicarbonate, holding on to protons, and things like that. So it has a big effect on affecting the serum pH. So you can see there's a wide range there in the kidneys for pH as well, because it can regulate that. I mentioned weak acids are going to generally be excreted faster in alkaline urine. Because we can put weak acids into a basic solution, they're going to be more protonated, harder to be reabsorbed, they're going to be eliminated more quickly. Weak bases generally get excreted faster in acidic urine. So again, if I had weak base, it's in acidic urine, it's going to be in a more charged state because it's protonated, it's going to be eliminated more quickly. And so what you can end up seeing is trapping of these substances based on pH changes. So that can include the stomach, small intestine, breast milk. So when we talk about things like pregnancy and lactation, you can see drugs actually being trapped in the breast milk because there's some changes in pH that happen between the tissue between the bloodstream and to the breast milk. Aqueous humor in the eye, vaginal prostatic secretions. So all these things can affect where drugs are getting trapped at based on changes in pH. So for instance, if something's in the blood, it's in a lipophilic kind of state, in an uncharged state, it crosses over into a substance that's either more basic or more acidic, and now it becomes charged, can't get back across. That's the kind of trapping effect we're talking about there. So I mentioned aspirin being a good example of utilizing this for clinical benefit. It's a weak acid, and if I can put it into a more basic medium, by increasing the pH, usually by giving sodium bicarbonate in the IV. Basically, we can prevent reabsorption and allow for faster elimination of the aspirin through the urine. And so you can even see this. So it's nice when you're dealing with these kind of patients and you're following them. You'll be doing serial levels of the drug. And so, patient comes in, they overdose on aspirin, you see the level go up really high, and then you give them the sodium bicarbonate, and then you can see the levels start to drop pretty significantly. So that's one really good way we can use to get rid of aspirin more quickly. So clearance is another way we're going to talk about this elimination. Basically, it's going to be the amount of the volume of blood that gets cleared per unit of time. So this can usually be expressed as mLs per minute. And just realize that this is describing elimination of all drug through all kind of routes throughout the body. So especially if drugs have multiple routes of elimination, you can kind of add these all together to get kind of clearance total. So if you have renal clearance, liver clearance, biliary, other, all that can be kind of added together to get the total clearance for a drug. So clearance is really, really important because this helps to determine what drug concentrations we're going to have. So again, if I have poor kidney function and I'm not able to clear drug very well, what does that do to the drug levels in the serum? Should go up, right? If I can't get rid of it, it's going to stick around in the bloodstream. Versus if my kidneys working very well, should get rid of the drug more quickly. And so basically the way that we can equate renal clearance of substances and correlate this back to renal function is by using what we call creatinine clearance. You guys familiar with this term? Essentially, creatinine is going to be this byproduct of muscle metabolism, and your body makes it at a pretty constant rate during the day, right? And it only gets filtered, filtered and then excreted through the kidneys. There's no reabsorption of it, and there's no secretion of it into the urine. So because of that, it's a really good surrogate for how well the person is going to be clearing creatinine and consequently other drugs as well. So for instance, someone who has renal failure, do you think they'd have a very high creatinine or very low creatinine? Should have a high creatinine, right? Because of the fact they can't clear very well. So they have poor kidney function due to, whatever the problem might be. If it's, hypotension, if it's due to acute kidney injury, whatever happens to be, the higher their serum creatinine is, chances are the worse their kidney function is going to be, right? I'll show you some ways we can calculate that in just a second to give you an example. Serum creatinine, though, is typically, you'll notice a range between, say, 0.6 to 1.2, but this can vary widely depending if you're dealing with like a pediatric patient versus if you're dealing with a very elderly patient. So, but this is a general range for an adult patient, typically somewhere around here. And so we could actually measure all the creatinine that comes out of the urine, over a 24-hour period to get the most accurate estimation of what their renal function is. But that's pretty cumbersome, right? Like if I told you to pee into a jar for 24 hours straight, that'd be pretty tough to do, right? Especially if you're trying to sit in class for 8 hours straight, your neighbor's not going to like you very much. Okay, so we don't do that. So we just use basically a single serum creatinine measured off of a basic metabolic panel, right? So have you guys covered that in Clin Lab yet? Like Chem 7. Remember that has like normal electrolytes, has your glucose, but serum creatinine is one of the big things you actually measure on that, and this will give you an idea of what the renal function is doing. So this is the more typical way we're going to be measuring this. So Cockcroft-Gault is a really good kind of all-purpose equation for determining renal function, especially in adult patients. This does not really work for pediatric patients. This doesn't really work for really elderly patients due to some factors which we'll talk about. But this is a really good one to use for most adult patients. I'm not going to ask you to calculate creatinine clearance on a test because if you ask me to calculate someone's creatinine clearance, what am I going to do? I'm going to grab an app, or I have a med calculations app that I can pull all that stuff from. Just like I couldn't tell you how to do BSA off the top of my head or body surface area, but I have an app that can do that, right? So I'm not going to have you guys calculate this specifically, but it's important to know the factors that go into this and how it will affect your creatinine clearance. So one of the first things we're going to look at is going to be age. So if you imagine the larger the age, what does that do to my creatinine clearance? Cause it go up or go down? Should go down, right? Because this difference is going to be smaller here, right? So if I had someone who was a lot younger, though, so say like a 20-year-old patient, you find a pretty big difference here, and that would cause your creatinine clearance to go up. And again, that's trying to factor in the fact that just as a natural process of aging, your creatinine clearance is going to get worse, right? So an 80-year-old patient is going to have a lot worse function, typically, even if they were otherwise healthy, than a 20-year-old patient. So age is one of the big factors here. You're also going to look at their weight in kilograms. That can have an effect on the creatinine clearance as well. You'll find that, especially when you're dealing with especially obese patients, that this can kind of be kind of a misnomer, right? So for instance, if I was dealing with, say, a 500-pound patient, they happen, especially if you're working like medical ICUs and things like that. Are they really are they probably mostly muscle at that point? It's a lot of adipose tissue, right? So you have to take that into account. So sometimes we'll actually use what we call adjusted body weights, where we can actually try to factor in to try to get a better idea of how much muscle they actually have to produce creatinine, right? Because again, it's not going to be, for those patients, they don't have a 1-to-1 ratio of when they're putting on weight of adipose tissue to muscle. Most of it's going to be adipose tissue for them. So we'll look at their weight. And that'll have a direct factor. So increase in weight usually has an increase in creatinine clearance. And then we'll have the 72 times their serum creatinine. So again, larger the serum creatinine does what to creatinine clearance? Right, you'd have a larger denominator, so it should cause creatinine clearance to go down, right? So there's an inverse proportional relationship there. And then notice we multiply by 0.85 for women. Why do you think that is? It has nothing to do with the wage gap, I can assure you. It's a bad joke, I'm sorry. So think about like who, if you were looking at, say, 100 kilogram male versus 100 kilogram female, who has more muscle mass on average? The male probably, right? So you factor this into the fact that women typically have less muscle mass, and so they're producing less creatinine at baseline, and so you factor that in. So you take this whole equation. If it was a male patient, you'd be done. If it was a female patient, you multiply by 0.85. Okay, so that'll give you roughly their serum creatinine and tell you roughly how well they're processing things throughout the kidney. Again, there's other formulas that we use more specifically for children, for elderly patients, but this is a pretty good all-purpose one that we use for these guys. So what do you think would happen if you had a patient who had an amputation? What would go down? Their weight would go down. That'd be one thing, for sure. I don't advocate that as a weight loss plan, though. Oh, why? Absolutely. So they have less muscle, so they don't produce as much creatinine. So that's one of those things where you can find patients, especially when you're looking at diabetic patients, you'll find that diabetic patients have increased kidney damage that happens over time. Chronic kidney disease is a very common comorbidity with type 2 diabetics. What you find is that, say for instance, they had an amputation due to the fact that they get really bad, they have neuropathies, that they can't feel their feet and they get injuries and things like that, and eventually sometimes have to get amputations done, and so that will falsely lower their serum creatinine and will make their creatinine clearance look better than it actually is. And so you can falsely overestimate that. And so when you're trying to dose drugs, oftentimes you're looking at the renal clearance and saying, like, okay, well, if it's between 60 and 90, I dose a drug like this. If it's between 30 and 60, I do this. And so those patients can end up kind of blurring the line a little bit because you're falsely overestimating what their creatinine clearance is. Okay, so keep those kind of things in mind when you're dealing with kind of patient unique things about them. Looking at normal creatinine clearance, typically you'll do this as mLs per minute, and sometimes you'll see it as like per 1.73 meters square. That's just their body surface area. So you use that to be able to equate it to different people who may have different body surface areas. But essentially, average is about 120 for male patients with a range of say 97 to 137-ish. Just know, creatinine clearance around 100 or so is usually pretty good for guys. And again, for women, 95 is the average, 88 to 120. So around 100 creatinine clearance of mLs per minute, like that's usually a pretty good creatinine clearance for the most part. And so it's when we start to get below that is where they see decreased clearance of certain drugs. So, you can have patients who have a creatinine clearance of 15. They have really bad kidneys and are just not clearing drugs very well. They can have a creatinine clearance of 0 in some cases where they are just anuric, they're not producing any urine, there's not really good kidney blood flow, and so we have to usually give them things like dialysis to help clear stuff out of the blood. Okay, so those are really important concepts that we'll feed into the next time we have pharmacodynamics, I think Thursday. Is there any questions you guys have before I let you go? We'll continue our talk of clearance and half-life and steady state and all that fun stuff next time. All right, I'll give you a 10-minute break and we'll come back and do the review for physio.